Welcome to the Ailm Practice Education Series in partnership with Firm Media, delivering concise and impactful insights for aesthetic and specialty medical practices. Your host, Chris Solhonik.
Today, we're going to have Dr. Isakson, a board-certified plastic surgeon from San Antonio, Texas. We're going to talk about cannabis, nicotine, and plastic surgery. Welcome, Dr. Isakson. I'm so glad you're on the show.
Thank you so much for having me. I'm really excited to be here.
Hey, do me a favor. Give us a little intro. Tell us about yourself, how you ended up, what made you choose plastic surgery, and how you ended up in San Antonio.
Absolutely. So, I've always loved kind of medicine and the kind of standard helping people stuff. But I always knew I liked working with my hands. I liked fixing problems. And so I was always drawn to surgery. And as I was in my training, I realized plastic surgery is one of the last true general surgeries. When you're doing plastic surgery, especially in sort of an academic setting, you're really the only surgeon who is operating on every age group, from newborns to people who are in their 90s, from every organ, from hair to skin to fat to muscle, nerve, tendon, and every part of the body from head to toe, literally. So every tissue, every part of the body. Plastic surgery is innovative. It's both general and it's also problem solving in 3 dimensions. So all of that kind of really interested me. It didn't hurt that it's very competitive, and so am I. So it was a challenge, and I really relished the opportunity. And then as soon as I got in, I was hooked.
So I know you to be competitive and analytical, so that fits. Tell us about your education a little bit. I know you went to school in Ireland.
I did, yeah. So I did my medical school in Ireland, in the south of Ireland, and they would call the true capital of Ireland, in Munster and Cork, at the University College Cork. I was there for 4 years. I did a 6-year residency at the University of Oklahoma in plastic surgery. So I'm board certified by the American Board of Plastic Surgery. And I did a year-long fellowship in aesthetics. So I've basically focused entirely in aesthetics, which is still a very broad field, but I've managed to kind of narrow that down into almost entirely aesthetic surgery.
Okay. And now you're in San Antonio?
I am, yeah, San Antonio, Texas. Just the right distance for my mother-in-law. She's in to help with our kids every once in a while, but no, I'm just kidding. Don't tell her what this is.
Really?
No, it's great. I love San Antonio. I can be outside a lot. The weather's favorable to all the things that I like to do and being outside. So it's great. If I can be outside, in the water too, if I can find some, basically anything. You find something that's outside, and I'll try and have fun out there.
Cool. And I know you're at the San Antonio Plastic Surgery Institute with Dr. Deckard, right?
Right. That's right. I landed in a great spot. Surgeons and maybe medical practitioners in general can be, an interesting bunch from, a personality perspective, but Dr. Deckard's a great guy. He's got a very similar philosophy. I like having patients in high fives. You can't ask for better than that. So if you're taking care of people and doing the right surgery, that's the way to go. And he's got a very similar philosophy.
Sure. And his feet are on the ground. He is a good guy.
Yeah, absolutely. Yeah, like I said, I'm a lucky guy. I can't say enough about how lucky I am. I got lucky with getting into plastic surgery. I got lucky with my family, my kids, my practice. Luck has followed me everywhere I go. I could talk about how lucky I am all the time.
Sure. So the topic for today is cannabis, nicotine, and plastic surgery. And you and I had exchanged some social media posts and some reels. One of the things that you were talking about in one of your reels was nicotine and healing and cannabis and all that good stuff. And I thought that would be an interesting, that's where I got this, was a reel that you sent me. I thought would be an interesting topic for the show. I think, the sort of people getting comfortable around the topic of cannabis, obviously that's opening up a little bit. And so I thought, what a great reason to have you on the show. The format of the show is to ask 3 questions. The 3 questions are sort of drill down into the center of this topic and give people useful information so they can either apply it to their lives or to their practice. So some of the people that might be interested in this episode could be plastic surgeons or people running their practices, and then also patients or consumers who might be interested in how they should show up for their consults or show up for being ready for their surgery. So you ready to get started?
Let's do it. Yeah.
Okay. So first question, what does the latest evidence reveal about how nicotine and cannabis use affects wound healing, recovery, and overall surgical outcomes?
So, I'm going to limit my answer predominantly to plastic surgery, to be honest. And plastic surgery is kind of unique compared to other surgeries in that it's very dependent on blood supply and wound healing. That's kind of what I do. And a lot of the techniques that are involved in plastic surgery kind of interfere with wound healing. It's not a straight line incision and then closure. There's maybe some tension or some interference with the blood supply to make everything look as good as we possibly can. So anything that interferes with blood supply really has been shown over and over and over again to increase the risk of complications. And so nicotine is one of those things that we've studied for a long time. We've got a lot of evidence, about long-term risk, short-term risk, and also kind of surgical risk. So from a nicotine perspective, just from plastic surgery outcomes, we know very, very strongly that it interferes with wound healing, increases your rate of all kinds of complications, major and minor. It also increases your risk of problems with anesthesia and a number of other things that can happen. So, anytime that you're obligated to do surgery on somebody who smokes, so it's an emergency or some other sort of reconstructive thing to happen for them to be able to kind of survive or live a life. You're obligated to do a surgery on somebody who's got nicotine use issues, or they smoke or they vape or whatever, you're going to see problems. And we can see that repeated over and over again. So it's not like the jury's still out, or maybe it does, maybe it doesn't. We've seen this happen over and over and over again. So nicotine, we've got a pretty good idea about what's going on. Are there medical uses of nicotine? Well, nicotine is FDA approved for something, which is smoking cessation, but it's actually the nicotine, not just the cigarettes, not just like the freshly combusted stuff, but stuff that you're getting in a vape or even in a patch or some other FDA approved replacement therapy. The nicotine chemical itself is really something that's causing these problems. It's not like the mechanism you're taking it by. It's not the fact that the cigarette's on fire or there's glycerin or whatever the carrier is in your vape juice. It's actually the nicotine itself. So are there medical uses for it? Sort of, and it may be neuroprotective in some ways, but from a plastic surgery perspective, usually a surgical perspective, wound healing in general, nicotine's a no. So we know that. That's repeated regularly in the literature.
Somebody was using chewing tobacco or even the patch or Nicorette.
Absolutely. All of that is extremely deleterious. So the nicotine molecule itself, it's, again, not just smoking, not just the lung problems, right? Okay, maybe it's interfering with oxygen delivery. Yes, it is absolutely interfering with oxygen delivery, your ability to exchange oxygen in your lungs, but it's more than just that, right? Yeah, okay, there's carbon monoxide in a freshly combusted whatever you're smoking, and that's going to bind to hemoglobin and decrease your ability to deliver oxygen. Okay, all that's true too, but nicotine all by itself is doing even more than that. It's going to actually cause vasoconstriction, so it's tightening the blood vessels. That's why people who smoke tend to have really cold fingers. They get really pale, white, cold fingers, and all that is associated with what's called vasoconstriction, where the blood vessels are tightening. All that is something that I do not want to have happen if I'm, for example, doing a breast reduction or a breast lift and my nipple is surviving on one little blood vessel. It also interferes with chemotaxis, which is the ability of cells, and in this case, white blood cells, to get out of the bloodstream and go somewhere they need to go, right? Your white blood cells, your inflammatory response, your immune system is traveling about your body and your blood vessels and your lymph vessels, but it's got to know somehow to leave that vessel and go somewhere else. If I make an incision and there's a little bit of fat that's dead in there or something, just because microscopic amounts, I'm not leaving a dirty wound, but your body's able to take care of that. And it goes, white blood cells that go in there and eat stuff and mediate an inflammatory response. None of that works very well in the setting of nicotine. So it does all kinds of cool and interesting and bad things on a molecular level and a physiological level on multiple levels that interfere with my ability to do my job. You know what I mean? Even the lung stuff is a problem, because if you've got a reactive airway disease and you're coughing like crazy, and I just did a tummy tuck or something else on your breasts where you might have a blood vessel that pops, or the muscle repair that I do fails because of a bout of coughing that you wouldn't have had otherwise, So, smoke, it's not just the smoking, it's the nicotine in general, partly some of the delivery, the way that you're taking it, but it is the nicotine molecule itself, whichever way you're taking that.
Okay. So apply that same question to cannabis. Where we at with cannabis?
Yeah. So there it gets pretty interesting and a little bit more complicated, and definitely a lot more of a gray area, right? So, the establishment and kind of community feelings about cannabis have been changing, right? It's changed dramatically. If you look at public acceptance levels of marijuana use, it's a curve that's only recently changed to the majority of people approve of it from the majority disapprove it. And that's only happened over the past decade or so. So public perception is changing dramatically. Last I checked, I think 38 out of the 50 states have approved some sort of medical marijuana, and then almost half of the states have approved recreational marijuana. Again, that's significantly different than certainly when I started medical school, and certainly when I was in high school or something like that. It's much different. And so the way that we've done these studies is different, right? We probably didn't have as many people who were as open about their cannabis use 20 years ago when we were doing research, whereas people didn't care whether or not they were smoking. The other thing is that, especially previously, and still now, it's hard to take apart people who smoke cannabis or use cannabis and people who smoke cigarettes. That for a long time was a population that overlapped dramatically. In fact, a common way of taking cannabis products is mixing it with nicotine, with tobacco products. It's hard to say, well, these people are using weed and they're having these wound healing problems. Yeah, but they're also positive for nicotine, and we know nicotine is causing these problems, right? So that's one thing. But like I say, medical marijuana is out there in 38 out of the 50 states, something like that. And so medical implies that there's some use for nicotine, right? And so I think last I checked, the vast majority of medical marijuana things are about chronic. And so the best evidence that we have for why we would use medical marijuana is really chronic pain. There's also some kind of chemotherapy-induced nausea and vomiting. So if you're on high-dose chemo, nausea and vomiting is notorious, and it's a really challenging symptom to take care of. And there's pretty good evidence that the cannabis stuff can help with people who are in that difficult situation. There's some muscle spasticity stuff with cerebral palsy and that sort of stuff, but it's also got pretty strong evidence in. I don't really do any of that stuff in plastic surgery. I'm not using it in my practice. It'd be nice if it was good for pain control. There is some evidence that can help with pain, obviously with chronic pain. But acute pain is kind of a different picture. The kind of stuff that you're going to get from an incision that I do is different than somebody who's got a chronic pain associated with a traumatic injury from a decade ago or whatever, right? Any number of reasons for chronic pain. And so they're two different entities. They're related, obviously, but I would call them different entities. And you're going to take care of them differently. And again, the literature is a little bit mixed as far as giving people cannabinoids. And the other problem is that when you're blind to these things and you're not used to being stoned, one of the main side effects is people are getting really uncomfortably high, right? As you're giving them higher doses of a cannabinoid, people are getting uncomfortably high, or they're falling or doing other dumb stuff because they're stoned. And so it's harder to tell if there's a big difference. Nausea and vomiting, for me, that's very important, and it'd be valuable. As far as what can it do wrong, there's not a lot of evidence that it's interfering with wound healing all by itself. So we do have some people who say, I'm an isolated cannabis smoker, I'd like to have surgery. It's really hard to do a randomized controlled trial with those people in general, well, for a lot of different reasons. But there's no strong evidence that it interferes with wound healing. There is some molecular evidence or animal model-based evidence that it might be helpful for wound healing, right? But then again, it also will kind of depend on how you're taking it. If you're smoking marijuana to get high, you're, by virtue of that, inhaling a bunch of combusted materials that are not cannabinoids. You're going to include carbon monoxide, all kinds of crazy stuff. In general, that's going to increase your risk for reactive airway disease, asthma, coughing, that sort of stuff, which I don't want. And it's going to interfere with oxygen delivery, which I generally don't want. And so, am I going to be prescribing it in my practice? Unlikely. Certainly not to somebody who doesn't talk to me about it in the beginning. If you're naive to cannabis, I don't think it's a great idea for me to say, I want you to smoke 2 joints a day after surgery, or even doing edibles or some other way of doing it. I think people's dose responses to cannabis is so varied, especially, and it depends on what you're trying to achieve. Are you trying to get a macro dose, like you're really high, or are you trying to get some other dose that's not necessarily going to be giving you those cerebral effects that might, change your perception of pain? Maybe there's a lower dose that can do that. We don't have a lot of good evidence for that, especially, again, in acute surgical pain. And the evidence we do have is mixed. So some papers have shown that, you can give people this and it doesn't really change, or you can give people this and they use slightly less morphine or narcotics while they're in the hospital, and it might be significant, or it's only kind of significant. But, so right now, as far as, is there a medical use for a surgeon in my practice? Probably not. That being said, the same is true of nicotine, but I still, encounter it in my practice, and I have to have a way of kind of managing, right? And so increasingly, people are more commonly either on medical marijuana or just, recreational marijuana or cannabis of whatever variety. I got to be able to deal with it and have an idea of how to talk about it. And I think
So
that
let's explore that a little bit. What proactive guidance do you provide patients who disclose nicotine or cannabis use to balance safety and potential patient-centered care or outcomes?
Yeah. So with smoking or nicotine in general, I'm upfront with literally every single patient because a lot of people understand kind of long-term issues with smoking, but don't really understand some of the issues with vaping or what I would consider the short-term effects of nicotine, which are really what I care about in plastic surgery. So I do try and make sure people understand, regardless of what you're doing, vaping, chews, patches, gums, hookah counts. Some people are like, a hookah, I didn't realize that mattered. Yes, it counts. All that stuff, I need 6 weeks of strict cessation. There's some variety in the literature. Some surgeons are like 3 weeks, 4 weeks. I would rather be safe than sorry. The surgery that I'm doing is elective. I'm not saving somebody's life. And frankly, if I'm doing a breast lift and my goal is as good of a result as I can possibly get, I don't want to take any chances. I'm bending over backwards in the operating room to get as good of a result as I can, spending extra time for maybe marginal benefits, not a lot, but doing everything I can within reason to get a good result. And I need that, in kind. So it's a teamwork. And so 6 weeks cessation is what I go for. And I also will context that within the idea that I understand that quitting smoking is literally one of the hardest things a human being can do. Nicotine is among the most addictive substances on the planet, and not smoking can be very challenging. But I would rather postpone a surgery because somebody fell off the wagon or whatever than do the surgery and wind up with a dead nipple or some huge wound that we're babysitting in the office. And it's just terrible. I'd rather not do that.
So how often do you find that where you've asked somebody that they have to take 6 weeks off and then they can't do it, or they want to go forward anyways?
It's happened a few times. And it's actually been kind of satisfying because in the beginning, it's very frustrating. You have to reschedule a surgery, something like that. But I've helped several people actually quit smoking altogether, which has been very good for their health overall. And so, a big part of what I do isn't so much helping overall health frequently, but I can. And when I do, it's very nice, right? And so that's one opportunity that I have. And it's changed kind of a negative situation into a positive, actually having somebody be able to come back and be like, yeah, this has been great. My breathing's better, my exercise tolerance is better, I'm doing all this other stuff. I don't smoke, let's do surgery. And it's 6 months later or something like that, which is cool. But I've also had the opposite, right? Either people didn't understand that whatever they were doing had nicotine, like hookah, or they just didn't really think that it was a big deal. And that is, I've seen the negative consequences from a wound healing perspective. Somebody who's had a bad problem from a surgery that's almost certainly because of the smoke. Obviously, they wouldn't have had a wound if they hadn't had the surgery, but that's not a normal problem to have outside of people who are smoking. If that makes any sense.
So that sounds like the smoky cessation sounds like nicotine. What do you tell people who are smoking cannabis or smoking weed?
So that's again, it gets into a bit more of a gray area, right? In general, I tell people, probably smoking any freshly combusted plant material. I wouldn't get in a forest fire right before your surgery. I wouldn't smoke cigarettes. I wouldn't smoke whatever leaves you pick up off of the ground. That's probably not going to be good, whatever chemicals are in them. So smoking, probably don't do that for several weeks before the surgery. The main thing I'm worried about is kind of carbon monoxide and stuff interfering with oxygen exchange, right? Oxygen exchange, kind of reactive airway stuff, winding up coughing in the operating room or when you're recovering. I don't really want that stuff if we could possibly avoid it. But then, okay, what about edibles or patches or all these other ways that people are consuming these products? And frankly, I don't have a big problem with it. I think there's some evidence that it can help with wound healing, it can help with nausea. And again, if you are somebody who's not naive to these products, who's used it before, you understand your own tolerance, you understand kind of how your body is metabolizing it. You're not going to like eat a brownie and then be like, oh my God, call the ambulance. You're going to have done whatever you've done before, right? And so I'm a little bit more comfortable saying you understand the side effect profile and what it feels like. And so it might help, right? If you have trouble with your appetite or nausea and it helps with that, then it might help after the surgery too. And I think, postoperative nausea and vomiting is a perennial problem that is terrible. Nobody wants to be nauseated and vomiting, especially not throwing up after a surgery, right? So if we can do anything to reduce that, I'm all for it. And the same thing as far as nutrition, right? You need to be able to get nutrition and have food taste good to you. And sometimes immediately after general anesthesia, everything's kind of hungover, nothing's very good. I want you to be able to, stay hydrated so you get thirsty, drink plenty of fluids. And if you get some protein on board, that's awesome. But eventually protein is going to be key, a healthful, well-balanced diet. And if you just have a tummy tuck and your tummy's really tight, you might be able to enhance your appetite a little bit, which could be helpful. In the long term, you don't want to overdo it. Obviously, you don't want to go in the other direction either. But
the macro dosing, right? But there's, so many new avenues for microdosing all kinds of substances, right? Whether it's THC or mushrooms or
the psilocybin stuff out there. That's getting again into some really cool, but slightly outside of my scope. I'm probably more about wound healing. If I can sometimes plastic surgery can be transformative, kind of inside, outside, fix a whole mental health problem, which is really cool. But again, I don't do as much of that. And there can be problems too, right? Chronic pain can happen after any surgery. And so those are all things that you'd want to avoid. And so if you can find a way of modulating the neurological response with cannabinoids, that's great. But by the same token, listen, there is evidence that cannabinoids around and during surgery can cause problems, right? There's some evidence of not necessarily increased mortality, but certain negative, mostly cardiovascular complications in people who are getting like knee and hip surgery. That's pretty mixed evidence also, right? It's hard to suss out exactly who's all cannabis, who's nicotine. It's hard to, that's maybe not the same population. People who are getting hip replacements might not be the same people that I'm operating on. But, there are cannabinoid receptors in your vascular endothelium. Your blood vessels, your neurons have cannabinoid receptors.
Sure.
That being said, it's as far as I understand, next to impossible to take like distilled cannabinoids as an overdose, right? You'll fall asleep from smoking too much before you can take the time to take that much to kill yourself, because it's not present in the part of your brainstem that's involved in breathing or like that is regulating your heart. But there are things there's evidence that, your blood pressure can fluctuate either down or up, and it does weird stuff, right? Different things to different people. But some people get high blood pressure, some people get hypotensive or low blood pressure. And if you're worried about kind of potential effects of blood pressure, probably better to take a few days off before your surgery. And by the same token, anything that gets metabolized in your liver kind of changes what your liver does a little bit. So, people who drink a lot will change stuff, but most drugs, a lot of the things we take are metabolized in the liver through something called the cytochrome P450 systems. And that does a lot of stuff, but you can potentiate it and make it hypermetabolize or decrease it. And probably people who use a lot or the use of cannabinoids will be metabolized through cytochrome P450, but also kind of change the way it works just by virtue of the fact that they went through it. And that's a lot of stuff. So alcohol, any other of the drugs that we're taking are probably being metabolized through cytochrome P450 and are changing it. So it could change the way anesthetics are metabolized, for example. So there's some evidence that, you need a little bit more propofol, which is one of the drugs that we use to put people to sleep, in people who either chronically use cannabinoids or are actually high. I don't actually remember that study off the top of my head very well. But it showed that induction of anesthesia was the same, but to actually put an airway in, to put a mask airway, required a little bit more propofol to people who used weed or who were on cannabinoids. Sure. So if you got very low risk tolerance, or you want to do the absolute safest thing, well then just quit for a few days. Longer if your preferred mode of taking it is smoking, probably.
So this brings me to my last question. It sounds like you're pretty clear on nicotine. The verdict's out, right? Not good pre-surgery. Take a 6-week break. Should be all right. But cannabis. Public attitudes are rapidly changing around cannabis. How do you recommend surgeons sort of stay informed or adapt around protocols for this stuff?
Well, I think that is going to fall under the guise of kind of your standard continuing medical education, right? So the one of the impetus for me doing that reel that we had discussed was that, a paper was published about it. These people decided to publish a paper. We don't have to comment on the absolute quality of the literature that's come out, but, people are looking at this and they're thinking about it and they're talking about it. And so reading these papers is going to be a part of it. So understanding what's out there. But there are other challenges, right? I think these studies are difficult to do for a variety of reasons. They're difficult to control. It's difficult to get approval from governing bodies to say, yeah, it's okay for them to do weed. Because before I was like, no, this is going to hurt them. You can't ethically let somebody do this weed thing. They're whatever. So, and it was difficult to get, whatever standardized compounds, like you couldn't get weed to study it, right? You couldn't go to your street pharmacist and have some standardized, like this is 20% XYZ with this. You need to have standardized stuff to be able to do an experiment. Sure. And that just didn't exist, right? And so you're doing what I would call, you're getting dirty data, right? You're talking to people who maybe smoke this weed, but they get it from Joe Schmo down the road and his weed isn't good, but that guy's weed is really good or whatever.
Right. Apples.
And so it's been classically, in part because of public perception, challenging, science to do. And that's getting better and better. And so the quality of the data that we have are getting better, right? And so the same thing is true with nicotine. That's going down. Weed is going up. Now that might be changing a little bit with vapes and stuff and leveling out, but we're going to get more information. We'll know more with time, but also people's behaviors are changing, right? Like back in the day, people were not, number one, they weren't getting extremely high quality, high dose, high purity products that you can get now from medical dispensaries or recreational ones. And there also wasn't K2 or Spice or whatever the synthetic cannabinoids are, because those are a whole nother kettle of fish. Those can do crazy shit that other stuff can't do. Their affinity for those receptors, what even is in there that's a whole nother thing,
Sure. I really appreciate all those answers. That this episode of the podcast was super informative, super interesting to me. You and I haven't talked about this, but I have a degree in psychology. I don't know if I've ever told you that, but before marketing, actually started marketing, got a degree in psychology, went back to marketing. So I'm sort of in circles of people that are using the microdosing for things like PTSD and things like that. And so some of that stuff's relatively interesting to me, and I kind of keep close tabs on it. But the THC and cannabis, that kind of stuff, not really clear on like what it does to the body, not really clear on how it affects the body. Sounds to me like doesn't seem that bad. You wouldn't recommend smoking it right before surgery. Nicotine's an absolute no. Right before surgery, maybe 6 weeks.
It's mixed, right? Like the whole thing is mixed. I'd say even with cannabis, and that same is true with almost everything. Like you can probably do too much of something and it's a problem, but wound healing, there's some studies that are going to show that it helps. There's some that are going to show that it doesn't. With pain, there's some studies that show that it helps and some that it doesn't. And then does it even make sense? And with cannabis, it probably does. Like if you're looking at what receptors does THC act on, you're going to look at the endocannabinoid system, CB1, CB2, and then you're going to go, okay, where are those in the body? You can start to look at them and where are they in the brain? Are they in the amygdala or somewhere where you're generating these memories or negative pathways for PTSD? Maybe, in which case maybe there's some, blood-brain barrier thing where it could be useful as an adjunct. Yeah. Same with kind of vascular stuff. Like maybe, there's some sort of a vascular endothelial, like the blood vessels have these receptors. And there's some effect, right? And maybe we can use that as a drug target in the future, or even just kind of get a better idea of who's going to get high blood pressure because they use weed and who's not. And I think that's a thing. There are probably some people who maybe respond a little bit differently, and maybe even some different kind of cannabinoid products will affect these things differently. I don't really know. It's probably not bad, right? Probably, depending on what you're doing and how you're doing it and how you're doing, right? Everything in moderation, including moderation. Thank you, Oscar Wilde, for the philosophy. But like, it certainly is not like nicotine, right? But even then, like nicotine is, potentially neuroprotective, right? Maybe it can help with Alzheimer's or other stuff. Like there are those nicotinic acetylcholine receptors that are involved in some of these neurodegenerative diseases. And the same thing is true as far as in the vascular endothelium. Maybe there are drug targets that we can use nicotine to help. I don't know. I don't want to say everything's all bad or everything's all good. I don't want to sound too much like a lawyer either, but you can overdose on water. Water in its solid form will burn you. It's liquid and gas form is going to burn you. Water will kill the heck out of you, but we have to have it, right? So, I think if you find it helps, especially, right, if you notice that it causes some appetite things, it's helpful, or whatever, it helps with pain. I think that's great. If you just have a stressful day and it's like and you've got a problem with alcoholism and it's better than booze, that's great. Good for you. But by the same token, if you're like, yeah, man, I get scared, my heart rate starts going crazy, my blood pressure's going, I'm not going to tell you to go smoke weed after my surgery. I don't want you to do that. So I don't know, everybody should have chicken breasts and brown rice and broccoli and no salt or butter, and you should exercise every day. And I don't know. You got to live your life, have fun,
Fair. Dr. Isakson, this episode has been a lot of fun to record. This is the point in the show where I ask if you're Ailm Essential Insight. So one takeaway that you're going to leave either potential patients or other surgeons trying to run their practices with that might help them out.
So I would say, a lot of people know long-term stuff about nicotine, but within the short term, nicotine can be really bad for plastic surgery. I'm just going to say that a lot of people don't actually realize that. So that's an important kind of takeaway. Short-term problems with nicotine are real, so just quit for a little bit and then get your surgery. And then if you need to smoke again, just get healed up first. Second one with weed, do what you want and what you know. If you know it's bad, it's not good for your mental health or whatever, don't do it. But if it's good for your appetite, if it helps with your pain, or it's just, like coffee or something, it's the same thing. That's what I would treat it kind of like that. Like a lot of people tell me not to have coffee after surgery because it can elevate your blood pressure. But me personally, I drink so much coffee. If I don't, my blood pressure's going up. It's a problem. I need to bring it down, right? And so there are exceptions to all these rules, and I think that you got to treat everybody as an individual. It's been a pleasure being on this podcast. I really think
Thank you so much for being on the show. That's all the time we have. I really appreciate you. I'll talk to you soon.
It's been great. I really appreciate it. Thanks for having me, and I hope some people learned something. If not, I had fun anyway. All right. See ya.